So regarding terminology, medication-assisted treatment versus what, and what was the rationale for changing the name, or who told you to do that?
Oh, sure. Yeah, I was actually going to throw it out later if I could steal your catchy coat terminology. The reason that we had this come up was we recently received a grant for expansion of medication-assisted treatment in rural Appalachia, and during the final phase of the grant, they asked that we change the wording, that we need to be more mindful of the terms we're using. So some federal grantors were very concerned about that term. And then we also had a recent sort of quality management retreat, and the speaker there was speaking about how medication-assisted treatment is in some ways stigmatizing or leading to perpetuation of stigma in some ways by treating like medications for addiction are somehow different than medications for other diseases. So they wanted us to stop using that term there as well. And so those two things are really what got me to where I'm going to try to find a better phraseology. But the one that the grantors had us use was MOUD, MOUD, medication for opioid use disorder. But I don't know, I just really want to call this a MOUD program. I thought COAT sounded better, so if that's smart, I'd like to use it.
Good. So very good. Thank you for that. What do other people think about the terminology of medication-assisted treatment?
Yeah, the only thing I brought up is that I had seen, I read, I think it might have been a SAMHSA publication where they thought that saying medication-assisted treatment may have alluded to underplaying how important the medication role was. So they advised using the words medication-based treatment, meaning that it was the primary means of the treatment. So that's...
Yep. Any other thoughts on that?
This is Jennifer Boyd from New River. I, at some point in the past year, heard somebody propose that we should call it treatment-assisted medication, but I don't really have an opinion on anything.
So this has been sort of a debate that has been in existence for a few years now by those of us in the addiction treatment community. And when office-based medication first became available for opioid addiction or opioid dependence at the time, nobody really knew what terminology to use about it. And nobody really knew, if you guys remember, it was about 2002 when it became, 2003-ish when it became approved. And nobody really knew, what were we going to do with this medicine? Was this a medicine that we were just going to detox people with? Was this a medicine that we were going to have people on for an extended amount of time? But the prevailing understanding at the time is that this was going to be medicine that was going to be used in conjunction with other treatments like therapy. And since that time, most of the evidence that has come out over time is that medications on its own seems to have much better outcomes as opposed to no medications. And medications, even with or without the other therapies, have good enough outcomes that most experts now in clinical guidelines would suggest, even if therapy isn't available or the other social components isn't available, you should give people access to medication, because if people don't have the medication, they're much more likely to overdose. And so many would really argue that it should be called medication for opioid use disorder, the way that we would consider antidepressants. Prozac is medication for depressive disorder. And calling it something else that assumes all of these other elements are going to be necessary in order to prescribe the medicine has limited its availability, and has limited, put unnecessary barriers as far as prior authorizations, various guidelines and state code, et cetera, et cetera, et cetera. And so now, as of today, definitely the medication for opioid use disorder appears to be the prevailing standard within a lot of the professional journals and other guidelines. However, if you look at SAMHSA and NIDA and some others, medication-assisted treatment still is the terminology that's used. So there hasn't been any sort of magic wand that says now it's time to change the language. What you've experienced already at Cabin Creek, however, is it's going to go, a lot of what you're writing for grants is going to go to reviewers, or if you're publishing, it's going to go to reviewers, and many will have very strong opinions about this particular issue. I am one who really likes the terminology of medication-assisted treatment, yet understand the rationale for getting away from that terminology. Why I like medication-assisted treatment is because I truly believe that addiction, like any other chronic disease or chronic disorder, has not only a biologic component, but also has a psychologic and a social component. And that for any chronic disease, trying to address all three of those domains is going to give somebody the best chance of a long-term recovery. And so I'm of the opinion that, for instance, had we looked at chronic pain of prescribing opioids for chronic pain, if we would have called pain pills medication-assisted treatment for pain, I don't think we would be in the same mess we are regarding the pain pill epidemic, because would have recognized that just managing with opioids was one of the modalities that could be used to help somebody with chronic pain. So in many ways, I wish, for instance, that insulin could be called medication-assisted treatment for diabetes, which recognizes the importance of the behavioral and psychological, social elements and therapies that are necessary to help somebody with a chronic condition like diabetes type 2, for instance, or even diabetes type 1. So, however, that being said, I recognize that I am in a small minority nowadays, and the world carries on. But those are my thoughts and my 2 cents regarding the matter.
That's excellent. Thank you. Did anyone have any comments or, agree with what Dr. Berry said? That was really, in depth and great. I agree with what you said.
Yeah, again, I guess I'm on a soapbox. The other thing that worries me about constantly changing terminology is that we lose credibility in the eyes of the public when we're constantly changing the names for some of this stuff. So that's one of the other reasons why.
Mm-hmm. That's true. I feel like we're still trying to get folks on board with identifying this as MAT and not just a Suboxone clinic.
Just a medication. So it's helpful when I speak before drug courts or lawyers or child protective services people or other community members. It's helpful to say medication-assisted treatment in the sense that we're not just writing a prescription, patting somebody on the head and say, come back in a month and get another prescription. That is more palatable to most of the people in the community.
Mm-hmm.
Does this mean we can call ourselves a coat clinic?
Can't they?
Why, yeah, as far as I know, you can. You're an official hub.
Yeah.
Why can't you call yourselves a COAT program?
I've honestly, the biggest reason I've always hesitated is I never feel like we'll ever be as comprehensive as WVU is, and that's the first letter in the acronym. So,
Well, but you are
might we just
providing
call
all,
ourselves an oat clinic? We could be an oat clinic.
there are some of those out there. I've seen those actually. Yeah, you bring your horse or your patient to provide services. But no, I disagree with you. I think you guys are providing comprehensive, much more comprehensive services than most out there. And you are providing both therapy, and you are also ensuring the social elements of treatment by having people go to peer support groups and these other things.
Mm-hmm.
So I disagree with you. I think that at least in the way we conceptualize comprehensive, you are providing comprehensive opioid addiction treatment.
You don't give yourself enough credit.
Well, thank you. It really helps. It helps us a lot. We're only here because you all are there to give us the confidence to do this. But in particular, I feel like we don't have residential options. We don't have inpatients. So I feel like to say comprehensive, I need to be able to offer all of the levels of care that SAMHSA has available, and I've been unable to do that.
So I hear that concern, and I would disagree with you. In my opinion, you're offering comprehensive outpatient addiction treatment. And it is rare that a system actually has all levels of care the way we do. I mean, it's very rare. We're fortunate in that sense, but please continue to think about what you're doing as offering comprehensive outpatient treatment for addiction.
Yeah.
That make us cougars. That make us cougars.
Yeah, were there any other comments or questions? I want to give some time for the didactic as well, but we could certainly continue any questions and discussions after as well. And again, please utilize the chat feature. It's really excellent. So why don't we go ahead and do some of the didactic portion, and then we can go back to any questions. So would you like me to pull it up?
You're gonna run it, right?
Yeah, I guess. Just say next slide. All right.
So now that we just had the medication-assisted treatment discussion, most of you already know about the medication-assisted treatment expansion project that we've been doing throughout the state of West Virginia with the state targeted response to the opioid crisis grant with the STR. So that's what we're going to talk about. Go to the next slide. So we have been going around the state implementing the COAT model, which is the Comprehensive Opioid Addiction Treatment Model that Dr. Morrison was just talking about. So we did it within 2 phases. So in the first phase, we trained hub sites in the COAT model to then train SOAK sites, which I'll get into that in a minute. So in year 2, we had the hubs identify smaller rural clinics around the state that then they could help us train and then provide technical assistance throughout the state. So here in Morgantown, we didn't have to do all of that training. Go to the next slide. So we are the main training hub here in Morgantown, and then we have 3 hub sites around the state. So it's WVU Physicians of Charleston, Cabin Creek Health Systems, and then University Healthcare Physicians of Harpers Ferry Family Medicine. So Cabin Creek, you are a hub of the COAT model. You can go to the next slide. So then we have 12 spoke sites, and we are hoping to add an additional 2 in the near future. So they're all scattered around the state. You can go to the next slide so they can kind of see it. So all of the dark blue squares all around the state are the spokes. So there are smaller clinics. So Camden, New River, Appalachian, they're all on here, Trinity, Northwood. So those are some of our spoke sites that are currently on the call that have implemented the COAT model around the state. So a few of our best practices that we have learned from the expansion is constant communication. So having communication with your hub and spokes constantly. We have in-person and video meetings at least monthly with all of our hubs and spokes on the call. And then Megan over here also has individual monthly calls with all of the sites as well. Some lessons learned, we have to have flexibility with each site. So some sites, for instance, they can only fit 10 people in their group room, as Katie is well aware of. Or some sites, the providers were just learning what MAT even was or getting their waivers, and then some already had experience with MAT. So, and then like community readiness, whether there's a lot of stigma in the community and we had to go there and really talk with them and do town hall meetings and that sort of stuff. And then to have some flexibility actually with the COAT model. So working with like trying to figure out and brainstorm peer support meetings and how we could come up with different ways to make that more flexible. You can go to the next slide, sorry. So we make all of our spoke sites come to our clinic here in Morgantown, and then the hubs that have their own spokes, they have to go to that hub site. So from whenever sites come here, here are just a few quotes that they say, like, this was an eye-opening experience. Going to the medication management group observation made so much sense, and how we're going to implement it in our practice. Every part of my observation of the program was useful and will be beneficial in our own successful implementation of the program. So whenever people come here, sometimes they're like completely anti-MAT, anti-doing this, and then they come and sit in Dr. Berry's group, and then they're like, oh, this was super eye-opening, and this completely changed the way that I look at things. Go to the next slide. So just a few data points. So everybody on the call that is involved in the STR expansion knows about the GIPRA data collection. So we have to do what is called a GIPRA, which is de-identified client level data on every patient at intake every 6 months and then at discharge. So during the STR timeframe, which was May 1st, 2017 to April 30th, 2019, we saw 686 patients. The average patient age was approximately 37. And we pulled a few different demographic things. So at intake, the majority of patients were unemployed, and then you slowly see that improve over time as you do more of the 6 months, 12 month, 18 month GIPRAs, you see that improving. Patient gender, it's pretty much equal, 51% male and 49% female, which is pretty amazing to look at. So what comes next? So now that the STR, we did get an extension, so we're still kind of going through the end of that for another couple months. But then we now have this state opioid response grant, which is the SOR. So that is to kind of help all of the hubs and spokes reach sustainability without grant funds moving forward. So it gives them a little bit more of a boost. We know that providers and therapists can bill for their services, but case managers cannot unless they're under a licensed behavioral health clinic. So, and case managers, as Katie and Dr. Barry can tell you, are very important in the clinic. They're kind of like the glue and help everything run smoothly. So the goal for the SOR is to increase patient capacity to build enough revenue to be able to pay for case management. Oh, no, that's all. So we also have a conference that is scheduled for all of our STR members that we are then doing focus groups in. So then we're going to learn more about our lessons learned, things that we've done well, things that we've done not so well, so things that we can improve on moving forward. So we hope to make it even better. So do you guys have questions, comments? I know that was kind of quick, as a quick overview of what we've done over the last two years.
Very thorough. Thank you, Shannon.
Yes, sir.
Does anyone that, like Cabin Creek or Jeremy or anyone that's a hub or spoke have anything to say about it? How it's gone so far?
I have a question.
Sure.
That 686 over 2-year period was the whole state?
No, just the clinics that were involved in the grant.
So all those dots on the map?
Yes. They all, it was like a slow progression of over the course of 2 phases. So they didn't all, some of them are just now starting to see patients.
Those are all the different.
Yeah.
So there might have been some people.
If we have the number anywhere of how many of those were re-entries of those 686, how many of those?
We do, yeah.
Oh, cool.
We were discussing at Cabin Creek about whether it's realistic to ever become a licensed behavioral health center so that case managers can bill for their services. Is that something anyone has pursued?
We can leave it up to everyone else, Ryan, but the way I understand it, being a FQHC is much more advantageous in the long run than being a behavioral health center. So I think, my understanding, again, I'm not an expert in this area, but if you have the FQHC status, which you do, that is preferable for a number of reasons than becoming a behavioral health center.
I could chime in on this a little too. North Licensed Behavioral Health Center, and the way the case management regulations are written by Medicaid, they call it targeted case management. Basically, none of the things that case managers in this program would do would actually be considered billable under that code. So it wouldn't be very helpful.
Thank you, because Jeremy, the way I understand the way case management would be things like, you know, going and finding people employment and other, you know, social services type stuff, as opposed to what we're doing with the case management, which is really specific for this particular clinical programming.
Yep, absolutely, that's right.
Jennifer, did you want to say something too? Did you want to add something?
No, sorry, I fell off the call for a minute and just dialed back in.
Oh, no worries.
Thanks so long.
Yeah, I'm driving.
Is there any way to see the impact of this program
on things like overdose rates and endocarditis and some of the measurable factors that could tell us what kind of impact we're having?
We were just talking about that the other day, Dr. Hirschler. We haven't looked at overdose rates, but that's something that would be good to, like, I mean, I don't know. Or
Where
endocarditis.
does data ultimately go? Like, who's going to do the final analysis on that?
It all goes to the state and then to SAMHSA. But we do have it that we can do some analysis on. So we did publish one paper. I don't remember. It was, do you remember when it was?
It was this year. I mean, it's 2019.
Yeah. With some GIPRA data, but it was limited. So it will be interesting to go back and look at more now. Now that there should be more of an impact, that it's at least been a couple years that all of the clinics have been going.
Sheena, is there any next steps in the works now? Is there another idea forming in there, or?
There's always ideas forming, Jeremy. So we did just get the year 2 SOR funds. And we do, I mean, we've been told that we will get a carryover of our year 1 SOR funds. So then hopefully we can help with the sustainability, and then we'll kind of see what goes from there. But
I also think I remember when our spoke visited Morgantown, I think I spoke with Dr. Berry, and we talked about, or he was talking about a kind of a unified front on getting, you know, some kind of fair payment for these types of services. Is there any kind of talk on that? We're talking about sustainability and MAT as a, you know, a legitimate treatment. So has there been any movement on that front in your experience, Dr. Berry, or is the state moving towards that, or any changes there?
Yeah, I don't know about specific changes right now, but I do know this, that certainly the Bureau of Health for the state recognizes how important this is, and same with the Center for Medicaid Services, and even the Office of Drug Control Policy and the Governor's Council, of which I'm a member of. So I think all of the forces are certainly unified in the sense of recognizing the value of medication and expanding treatment as much as possible and removing barriers. So I can't give you any specifics right now, but I've been encouraged over the last year to see a lot of that take place.
Great, thank you.
And you know, there's constant discussion regarding alternative payment models and other things, Jeremy, to make it more financially viable.
Okay, thank you.
One possible funding thing for ECHO, for people that participate in ECHO. We've started to talk with the ECHO Institute in New Mexico. They actually just got some Medicaid money to pay for ECHO and to give money to sites and things like that, which is traditionally hasn't happened. So we are starting to talk with them and see if we can replicate that here. There is some interest kind of with the same people. They know about ECHO and they, you know, want to see if they can do something for it. So, you know, hopefully we can get some more irons in the fire and get you guys some more resources, because you guys are taking the time to come here, which is greatly appreciated. But to give you guys something back to help your clinic, is what we want to do. So hopefully more on that to come, but something else.
Can you speak like of the mega hub or the designation as a mega hub or whatever?
Oh, super hub?
The super hub.
Super hub mega hub? That sounds great. It's kind of like the Oakland. So we are going to be, our designated technically right now is a super hub, which means we will be a training site for the ECHO model. So people nationally. So when people want to come and start ECHO projects, they can come to us instead of going out to New Mexico. We will be the easternmost super hub, which is pretty neat. And so we actually are leaving March 16th to go to training for a week. So, which is kind of funny. You have to go to a training, even though Zoom, anyways. So we're going to be out there for a week. And then once we come back, we will start the preparations to do our first training. We'll probably do two a year to start. And we've gotten a lot of interest from surrounding states that have joined various ECHO projects. I know we've had other states join MAT, obviously, but we're going to have hopefully some takers on in the beginning here. So more to come on that as well.
And Jay, can I just make my plug again? That's
Yeah.
exactly why we're trying to gather data from all of the users to find out, how has ECHO been successful? Let's try to capture that and articulate that. What could it do differently? And so when, WVCTSI's ECHO becomes a model for others and they're training others, we're really learning from the experience of all of you who are participating. So just throw that out there. So stay on after the session if you would.
So did anyone have any final thoughts or questions? Thank you, Sheena, for that wonderful didactic. It was really informative and great. Anyone had any questions, comments? Feel free to chat us or email me as well if you think of any questions after the fact, and I can make sure to have them answered for you. So I do want to remind everyone that if you are participating in the focus group, please stay logged on to Zoom. And just one announcement for the next session, it's going to be on March 9th. I can't believe I'm already saying March. And Laura Lander is providing our didactic on provider-related stigma. So keep an eye out for that. And everyone who is staying for the focus group, please stay logged on. Thank you. Thanks, guys.
Thank you.
Thank you.
Thanks so much.
Yep.